Again, for me, the importance of the immunology is going to be focusing on what is useful for you to know in your patient, and especially in terms of the disease progression and how your ARVs interact with this that happens. So we'll talk a little bit about some of the things that you see. So again, some of the things I will hope is very familiar to you, especially our interns who's just been to university. So I'm going to run through it like the race of knots. And we're going to try and just focus on, get to those key bits that's useful for us in terms of HIV specifically. So just to remember, we have an immune system is quite complex. We have our innate immunity, which are the bouncers. These are the guys who, your skin, your mucosal membranes, they're the big guys who just throw out everything that looks foreign that comes in. Then we have our adaptive immunity, which is the one we're going to talk about today. You'll remember that that's the clever one, and that is the army. So there's intelligence in our adaptive immunity. It's a little bit higher up the food chain than the poor bouncers. And you will remember that our adaptive immunity has got a definition. What makes it? Why do we call it adaptive immunity? And that is because it's clever. It can recognize a specific antigen. It can say, oh, hold on, that shouldn't be here. And regulation is part of that. It's able to say what is me and what is not me. And we know with autoimmune diseases that becomes a problem if you start getting confused about what belongs to yourself and what doesn't. And then very interestingly, it does have a memory. So if you get exposed to an infection or a virus now, next time you get exposed, it will remember everything you've learned from the last time. And as you all know, our vaccinations and etc. is all based on that wonderful philosophy. So we're going to be looking a little bit at the key players. And for me, immunology can get very abstract and can get very paper-based. And so I'm hoping, I think that you're young, you all at least seen a James Bond movie? We could talk about the Hawks, but it gets too political. But we're going to look a little bit about the interaction between the spy service of the body, which is your James Bonds, your 006s and your 007s, and the generals in the army. And when we speak about two major groups of cells in the world of HIV, we talk about our antigen-presenting cells. You guys will all remember. And these are our spies. They all have a license to kill. They're allowed to go into the periphery, into the tissues. They're allowed to kill whatever they see that is foreign. And they must bring back information. So when we originally, immunology of 10, 20 years ago even, it was thought that the only function of the macrophage was like cleaning up things. You just had to gather up and kill them. But it's actually now discovered that it's got a much more important function in that it actually takes information back to the generals of the army. So those are our antigen-presenting cells, and we're going to go through each one of these in detail. So that's our macrophage, our dendritic cell, and our B-Lymphocyte field worker. Then you've got your effector cells, and these are key cells. There's lots of cells in the immune system, but these are key cells that without which you cannot launch an immune response, and in this case specifically against HIV. You have your CD4 cells, your CD4 T cells, which are like the generals in the army. They don't do a lot of, they are able to have hand-to-hand combat, but a lot of their function is about activating other cells that has to go and do the job. So they coordinate the immune response. Then you have your CD8 cells, which is like your SWAT team. You guys have seen, you know, the guys in the big black bulletproof jackets and the big black helmets and the big guns and goes and blows up both Americans and hostages and everybody else. And then you have your B-Lymphocyte. For those of you who know the James Bond movies, that's Q. That's the clever guy in the attic who builds all the fancy weapons and can make the weapons specific to that specific, depending on getting the information back. But your army can't do anything if it doesn't have good information. So where do we find all of these? And this is also a little bit of immunology from varsity days. Remember, there's a primary places where they all get born, where they're all made. These are our nurseries, and this is where they mature. We know that our T cells, for example, mature in the thymus gland. That's like soldier school, where they go and get trained up. But our secondary lymphoid system is very important. You all know that the lymph nodes and the spleen are important places for our armies, our soldiers and armies to gather. But I want to point out that bottom there, which is your gut, your bronchus, your mucosa, and your nasal associated lymphoid tissue. So you've got lymphoid tissue not only in the classic places where there's glands, and all of those have got CD4 cells. Even some of the cells, the actual cells in the gut, that's not a T cell, some of them has got CD4 receptors, as they do in the mucosa, the bronchus. So that's, for example, one of the reasons why if you get HIV, your lungs become very vulnerable, because the natural defenses of the lungs, the CD4 defenses in the lungs, also get wiped out by the HIV. Mucosa, that's why we see a lot of mucosal conditions like candida, for example, repeated respiratory tract infections, otitis media. And it's not only because your CD4 cells have been wiped out, but actually because the lymphoid tissue in those areas have been wiped out. So this is headquarters. Okay. Headquarters mainly is the lymph node. We're going to look at the lymph node. And headquarters has got 3 levels. It's got a ground floor, it's got a middle floor, it's got a top floor. Okay. The ground floor is our medullary sinus. Here on the ground floor is where all the macrophages and dendritic guys report. That's where they arrive, that's where they gather. And if they need to, if they're activated, they will move up to our middle level where the generals have their offices. So here the CD4s and the CD8s sit. If you go to the primary lymphoid follicle at the top there, that is where you actually find your B cells and the paracortical areas. And the B cells are then the ones who can make their weapons. And our weapons, of course, is our antibodies. Okay, so those are the very specific antibodies that gets made. And this is just reminding us of some of these areas of lymphoid tissue, like in the appendix, like in the tonsils, and Peyer's patches. Let's start looking a little bit at these cells. Okay. We're going to start with a macrophage, which is a little bit in the bottom of the food chain, very important within our immune system. And can we remember where do they come from, the macrophages? Where do they get made? All cells get made in same place as the red blood cells. Made in the bone marrow. They started as a stem cell and then. Okay, good. So I'm actually going to teach you something, or you just go, oh, for God's sake, okay. You get made in the bone marrow, and then you get your stem cells, which everybody gets all excited about. There's a myeloprogenitor cell. But what's interesting is that the macrophage starts off as an ordinary cop on the beat in the blood system. So the monocyte in the blood system is simply a cop. It's not got any special privileges yet, and it stays within the blood tissue until it moves in bloodstream, until it moves into the tissue. And when it goes into the tissue, it gets a special status. It goes undercover, and it becomes a macrophage. It actually changes, and it gets this more amoebic-like form, which makes it possible to move through your tissues. And what it does is it does this lovely word called phagocytosis, where it actually kills and starts cleaning up. And it literally takes the virus and it rips it apart. You think like a paper bag, it will take it and rip it up in little pieces. And then what it will do after it's cleaned up as much as it can, or it's killed as much as it can, it will now take these little pieces and it's going to go off and it's going to go and tell the generals. Because the CD4s don't wander around. They stay in the lymphoids. If you're hungry, maybe you're all hungry, is that a Freudian slip? If you are in good health and you're not sick, then your CD4 cells are not doing anything. They're just sitting in the lymphoid tissues. So they're sitting waiting for something to happen. Your macrophage goes off, and then it's got this very interesting thing. And there's a lot written about that. I find it quite mysterious. HLA2. It used to be called MPCs. When I was doing Immunology many years ago, they've changed the name now to HLAs. And the HLA is something that you find it on all cells in the body, and it's the security pass. So for the macrophage to be able to go to the general and say, listen, I've got something here I want you to see, there has to be a way that the CD4 cell can say, sure, I'll speak to you. And it's a bit like that little security pass that it shows. And there's 2 main HLA molecules or receptors that we're going to talk about. There's HLA2 and there's HLA1. Very uncreative, and the reason why they 1 and 2 is because HLA1 has got 1 leg and HLA2 has got 2 legs. It's got to do with the little receptors that plugs into the actual cell membrane. So what the macrophage does is, remember, it's an antigen presenting cell, and it actually uses its security pass, it progs the piece of antigen on the end, and that is the way that it's going to actually interact. So it goes all the way off to the lymph node. There it arrives at our lymph node, goes to the T cell zone, remember, middle floor, more in general. And now what happens is the CD4, the purpose of the CD4 is obviously not to let HIV in. The purpose of the CD4 is to communicate with the security pass. And the CD4 cell is specifically able to speak to anybody who's got an HLA-2 clearance. You've got an HLA-2 clearance, then I'm happy to talk to you. So that is the way it checks the clearance. And then the T cell actually has a separate receptor that's going to look at this particular antigen. And the T cell is very clever because it can tell whether this antigen is problematic or not. So it will look at this antigen, and if it goes, oh, not good, the T cell will now start being activated. So it's no longer a quiet memory cell sitting waiting behind its desk. It becomes active and it starts to replicate. So you get massive clonal expansion of those CD4 cells, and they all have the same memo. It's like they've been given a picture, fingerprints, probably a picture, one of those IDs. These are the bad guys. And they can now go out and they can start to coordinate an immune response specific to those bad guys. The other thing that happens, which I haven't shown in this slide, is that the macrophage also gets activated. And that gets quite important when we think about TB. So TB, one of the main cells involved in keeping our TB bacilli from not making us sick is the macrophages. But it's only activated macrophages that can do that. The macrophages are quite sleepy. They'll drag the bad guy off. But only when it talks to the general does the general release some gamma interferons that actually activates the macrophage and makes the macrophage much more powerful and much more able to kill. So in TB, if you've got TB infection, like we all have in this room, right? Your TB infection is kept nicely under control by your macrophages. It makes a nice wall around it, makes sure it doesn't make any trouble. You get HIV, those macrophages no longer get activated, and now the TB can wake up, which is why if any of you've got HIV, you should already be on IMH. If you're not, please go and get some tonight. Just get when you leave. Okay. And there's just a lovely picture of this macrophage pulling in these different antigens. Okay, cool. Now we get to the dendritic cell, which has got some, so the macrophage is 006. It's got one clearance, HLA-2. The dendritic cell is 007. It's got two clearances. But the dendritic cell is interesting is that although it does have some phagocytotic, it does do some phagocytosis, it's not nearly as effective as the macrophage at killing things. But it's very good at bringing things back to headquarters. We'll see later why that's a problem when we actually talk about the infection of HIV. Okay, I'm not going to talk to you. You all know where it comes from? Bone marrow. And the cell that goes before it is also still the myeloid progenitor cell. Again, it starts off as a monocyte. So when you're a street cop in the streets as a little monocyte, you can be promoted either to macrophage or to dendritic cells. And when they go off into the tissues, they become now a dendritic cell. Again, they're going to pick up some bits of antigen along the way. But now this is where it gets interesting, because it's got two security passes. So the dendritic cell has got both HLA-1 and HLA-2. I just have to say I'm making it very simplistic, because macrophages also have a little bit of HLA-1. But not much, it doesn't express it nearly as much. The dendritic cell uses the HLA-1. I'm not going to confuse you. Just that you know, when you read the books, you'll get a fuller picture. I'm making it fairly simple. So the dendritic cell can now have got two security passes, so it can speak to two different groups. Firstly, it can talk, as we know, to the CD4 cell because it's got an HLA-2 security clearance. Great. Same thing's going to happen. It's going to talk to the CD4 cell. CD4 cell is going to clonally expand. And then the next one is it now has also got the HLA-1 clearance, so it can speak to CD8 cells. Now, CD8 cells is interesting because CD8 cells do go and clean up in the periphery. So when you first get HIV infection, and while the generals are still getting their hats on and sending off interleukin to this side and gamma interferon to that side, as soon as the dendritic cell activates your CD8 cells, the CD8 cells will start to clonally expand, and what they do is they get the picture with a license to kill, and they're already going off and killing HIV. So they're almost like an early response, and they're a little bit crude, and they're not as creative as your antibodies, but that's a first line of attack that can happen while you wait for the immune system to wake up. And there's a lovely, beautiful picture of dendritic cells, like under the sea or in space. The third one we need to talk about is our B-Lymphocyte. So we talked about Q, who sits in the lymphocyte and makes weapons, but he does have field workers. And he's got guys who are out there, part of the James Bond team, going out into the cells, and what they do is they pick up early signs of problems. They can also present antigens, just like our macrophages in dendritic cells. And it's also a way to have. Okay, so the B-lymphocyte also obviously comes from the bone marrow, but what does it originate from? It's not from a myeloid progenitor cell. Thank goodness. Everybody's just woken up. Well done. Okay, so your lymphoid progenitor cell is going to give you your B-lymphocyte. Natural killer cells and T lymphocytes all come from those. And again, the naive B lymphocyte is a passive cell. It does not yet do very much. It goes around quietly. There's a lovely picture. I love those receptors. The receptors looks like the pictures. And then, of course, the antibodies that the B lymphocyte makes looks exactly like it's made by the receptor. So there's a picture of your B lymphocyte that can also be presenting antigens to your dendritic cells. They can actually take from the dendritic cells. And what happens is that when they get activated, when they have interactions with dendritic cells or they have interactions with the T cells, they themselves become activated and can start thinking about making antibodies. So, some pictures of B cells. So let's talk about its security clearance. So the B cell has also got HLA-2 security clearance. And therefore, it has the possibility, as an antigen-presenting cell, to also present to your CD4 cell. But that's a fairly equal meeting. This is not just the macrophage reporting. When the B lymphocyte and the T cell meets, the T cell will go off and coordinate the army, and the B cell will go off and start making antibodies. And it's an amazing thing that the B cell has this possibility of creating weapons that can go off via drone, via remote. B cell doesn't have to go with it to go and kill these HIV viruses. And there's some lovely pictures of the antibodies that it starts to make, the secretory antibodies. And remember, your activated B cell is called a plasma cell. It's these very large cells. And there's some pictures of our immunoglobulins. I'm not going to cover this in a lot of detail, but you remember IgMs is a big, clunky kind of, so one that can be churned out very quickly. And it's like the prototype 1. It's a bit large and clunky, and it's not very mobile, and it's not very, it's not got low affinity. Although it's got lots of arms, it's not actually as sticky as the streamlined IgG, which takes a little bit longer to make. So your B cells will do a prototype 1, and then while prototype 1 goes off, this you all know, God. So one thing from university I remember remotely is that, of course, your IgMs is what you see first. With your acute infection, your IgG is going to take a little bit longer. But the second time you get exposed to the same organism, you will have a nice, early, massive IgG response because your B cells remember. You all know this. I can move on swiftly. Okay. So let's just talk briefly about the actual cells at the bottom. We've actually already talked about them, so some of this is just going to be revision. If we say it enough, you don't have to go home and read it again. So we've got our CD4 cell there, and we've already said it's got these two receptors. It's got the CD4 receptor, and it's got the actual T cell receptor. You all remember where that comes from the lymphoid progenitor cell. And of course, the T cell is a slightly different story. It's going to go off to the thymus first, where it's going to go to soldier school and become mature. And then once it's mature, it will go through the blood and lymph tissue. It will circulate, but eventually it will go to the secondary lymphoid tissue. And that is where the CD4s live when nothing's going on. And quite often, if we're really well, we shouldn't be under attack too often. So your CD4 cells generally is fairly passive. But now the CD4 cell can get activated. And we're now going to repeat, there are 3 cells that can activate your CD4 cell. Can you remember what they are? Macrophage, dendritic cell, and your B cell. Great. And they just repeat all the pictures there. There's the dendritic cell. It's got the HLA-2 clearance. So these are the 3 cells that's got HLA-2 clearance. There's the next one, which is your activated macrophage. Also got HLA-2 clearance. And there's your third one, which is your B-Lymphocyte. Has also got HLA-2 clearance. And with each of these interactions, something different happens. So there's a possibility of the immune system being, all the different aspects of the immune system comes into play. Right, so you can see this, our CD4 count, HLA-2. Our CD8 cells, who can speak to our CD8 cells? Great, excellent. So our CD8 cells, just to also go through, they go through exactly the same development as the CD4 cell. They also go to school in the thymus. They also end up in the secondary lymphoid tissue where they sit and wait, your SWAT teams, and they can get activated by your dendritic cells because dendritic cells has got HLA-1 clearance. Now, what's also interesting about the CD8 cell is the other place where we see HLA-1 clearance. And actually, every cell in your body has to have a security pass. So the way we know whether we are when the immune system goes patrolling the roads, is that every house, every cell should have its little HLA security clearance. And the cells have the possibility, if they are infected by an organism or they're under attack, that they can present an antigen. As a matter of fact, they present antigens all the time. And a lot of those antigens are self. So you can see, that's me, I'm presenting, this is what's going on in my house. The dendritic cell goes, okay, cool, no problem, okay, that's fine. Oh, no, I don't like that. That's you. Oh, something here is not good. And the dendritic cell can then respond to that particular attack. And your CD8 cell, because your CD8 cell has also got HLA-1 security clearance, it can actually do a little bit of a, if it goes out and it's attacking, for example, the HIV virus, it can go from a door-to-door campaign and literally go and find HIV virus to kill. Very good. Oh, how was that for a grand tour to immunology? Questions? Before we start looking now, we've got the virus, we've done the virus, we've done the immunology, now we have to do the meeting of the two. That's where it starts getting interesting. Okay, so this slide is one of those slides you should just know and be able to do in your sleep and draw to your patients and draw for your fellow doctors. And it's one of those slides that shows us what happens in the body over time with HIV. And we're going to particularly look at what happens with the virus in the body. But you all know this. This is the classic slide with HIV. When you first get HIV, your CD4 count is high. Over time, your CD4 count is going to drop as the virus destroys the CD4 cells. When you start off, obviously, you don't have virus. You're going to get a lot of virus. I'm going to cover that now. And you can see a little bit there the way your CD8 cells respond. They vary, and they actually come into the party and come and help when we have a lot of HIV. But we want to talk about what happens with the viral load. I'm going to start off with the transmission of the HIV virus. So there is our genital system, both the woman and the man. And both our mucosa and our genital system has actually not got a great protective layer. There's a nice, like a single layer of mucosa. And particularly in the transformation zone in the cervix. and on the inner cell of the foreskin of the man. But usually, actually, that mucosal membrane normally is good enough. You know, if you get to STIs, there's not a lot of STIs that move into the body. The body's pretty good at containing them on mucosa level. The HIV virus is sneaky. What it does is it's very small, and because it's so very small, the dendritic cells, like it should, start picking up on it. And where do we find a lot of dendritic cells in men? The immune system. It's got a special name. It's an island. The islands of Langerhans. You've all heard of those, yeah? So in the foreskin of the man, there's a lot of these islands of Langerhans. And your islands of Langerhans basically consist of lymphoid tissue made of loads of dendritic cells. Okay, so the cells in the Langerhans cell is actually a dendritic cell. So all the dendritic cells are sitting there waiting. Oh, look, there's something here. That looks interesting. So they pick it up. They don't kill it. It's very small. They take it. Great. So what do we have to do? We have to go and tell the CD4 cell. So it takes all these live HIV virus, carries it across the mucosa, and takes it all the way to the CD4 cell to go and report to the genome. And this is one of our great challenges, is that HIV keeps on having ways of almost using our very own system that normally keeps things out. It uses it as a taxi. And the one example that one said that I quite like, it's a bit like Jonah and the whale. So it takes the HIV in, but it keeps it, Jonah does not get killed until he gets presented to the general, and that's where the comparison obviously ends. Here's a picture of our Langerhans cell. And so now what happens is that all these first CD4 cells that meet the HIV virus, of course, they're also going to get activated. But also what happens when they activate is they now make lots of CD4 cells. And of course, the HIV virus is using those to replicate. And so in the beginning, before the body has ever heard about HIV, the replication is quite staggering in how many billions of replicants this HIV virus makes. And within a week or two, during this time, this will be disseminated right throughout your body. We call this phase, when it's on that up like that, the acute phase. And you can imagine, because there's so much virus, it just wipes out all the initial CD4 response. All the CD4 can really launch a response. So it wipes out all the normal lymphoid tissue in your gut, in your respiratory system. And so lots of people get symptoms during this time. They might come in with a respiratory tract infection, or they might come in with diarrhea. You have lots of CD4 cells in your neurological system, so they might come in with Bell's palsy or a Guillain-Barré, or they come in with shingles. And what's the HIV test? Negative, because we're testing for antibodies. Okay. So this is a lovely picture. If you look at this picture, if you weren't to ask, unfortunately I've got the answers at the top, but if you had to say which one was the healthy one, it looks like a nice clean one is the healthy one, isn't it? But actually, no, our gut is supposed to have lots of lumps and bumps because you're exposed to lots of foreign things. And what HIV does, as you can see, it just wipes out all of that lymphoid tissue in the gut quite dramatically. So great. So we've got dissemination. It's gone throughout the body, and it goes up. And at this point, the viral load will be in the millions. What is your HIV test? Negative, okay. If you were to have sex at this point, right? What is the chances of you transmitting the virus to somebody else? High. 1 in what? For a sexual act. It's about 1 in 3. Okay. It's a very high transmission risk. What is your HIV test? Negative, okay? So we get very excited about HIV positive people who wear condoms. Those are not the main people who are spreading the epidemic. It's much more a risk of you're somebody who's HIV negative and who has recently been infected with HIV. But there comes a point when the immune system is now woken up, CD4s have been, and remember your SWAT team is going to come in. Here's your CD8 cells. Your CD8 cells are starting to be, it's already being activated by your dendritic cells. The antigen is being presented. They're going out and they're starting to kill HIV as well as CD4 cells that are very heavily infected with HIV. And so at this point now, you can start to see the CD4 count, and then the viral load can start to at least drop a little bit. And you will see it is in conjunction with your CD4 cells starting to also come up. But we have another great thing that's happening, and that is that your plasma cells are starting to produce their antibodies. So they need 2 or 3 weeks to get started, to get activated, to have enough plasma cells that are activated, and they are starting to make anti-HIV antibodies. And those are the ones we can test for. So at this point, your virus, let me go back just to this slide, your virus is now going to start coming in, and you're going to actually get to a point where you're seroconverting. Now, if your virus is on that low point, that number 4 point there, right? At this point, what is your risk if you have sex of transmitting the virus to your partner? 1 in what? 1 in? 1 in 200. It's between 1 in 200 and 1 in 1,000. We call this the viral set point. And if somebody is very healthy, that viral set point can be quite low. And you can have somebody who's relatively well, and those are the people who stay well for a long time, and their infection rate of passing the virus on is relatively low, and that's where your discordant couples come in. So somebody's been infected with HIV, now they meet a new partner, they've been together for years, they've had 3 kids, they've obviously not had condoms because they're having kids, but the one partner now in her 3rd pregnancy, they discover she's HIV positive, and the husband's devastated. Where did she get the HIV from? Because I'm HIV negative. And that is the issue. They met here. And it's actually not that easy to pass HIV on. So although we get very excited about our healthy HIV positive patients, our challenge is still the people who have just gotten the HIV infection. So that's a slide I often draw for my patients to try and understand what discordance is all about. But the challenge with HIV replication is when we are looking at this control and when we watch that set point coming down, is that all of that control and set point is primarily happening within the bloodstream and within the active part of the lymphoid. So the cells that are getting cleaned out are our activated cells. But within the lymph node, you have memory cells. And about 1 to 5% of those, not a large percentage of memory cell CD4, so these are quiet, passive cells, are actually infected with the HIV virus. And the replication is slow, but they do replicate slightly. And then those that replicate will come into the bloodstream and be wiped out by your ARVs or be wiped out by your own immune system. But the problem is that we can't reach those. Our ARVs can't get there. And so when we talk a lot about control, there's this worry about these reservoirs, these places where HIV can hide from all our clever drugs. This slide just shows us how over time, as these CD4 cells get wiped out, you can imagine it's a war zone, how the actual lymphoid tissue becomes more and more fibrotic and actually gets wiped out. And that's one of the reasons where if you've got patients with very low CD4 counts, when you start on ARVs, we sometimes find the CD4s don't always recover back to that same normal CD4 count. And it's partly because the actual places where the CD4s normally live and are multiplying or getting wiped out. But of course, if we're talking about immune system, we have to talk about iris. You've all heard about iris. So the immune reconstitution inflammatory syndrome, and this is very important clinically. There are different types of irises and there's different classifications, but there's 2 that you need to know. And they're clinically important, and they also like to put them in exams. The one's called the paradoxical, and the one's called the unmasking. Their names actually tell you what they are. So the unmasking iris is the one we all sort of know about. That's the patient with a very low CD4 count, seems fine. You put him on ARVs, and now he gets sicker. And it can be anything. It can be any opportunistic infection. And what it means is that the opportunistic infection was there, but it was making the patient sick. So you would see your patient not 100%, maybe losing a bit of weight, but there was no real symptoms. Now, suddenly, when you start the ARVs, the CD4, well, we'll talk a little bit about the theories around it because we don't understand iris. Because what happens is suddenly there is an inflammatory response, as there should be, as we've been wanting against those particular organisms, but it's an overreaction. It's like the immune system has gone completely crazy. And there's a lot of theories about why this happens. We can describe it, but we don't really understand it. So that's unmasking. Infection was there, but it now becomes clear when you start the ARVs. The second time is paradoxical, and I still see this one catching people out. Classic one is TB. You've got your patient who comes in with TB on the wards, quite sick. You start them on the TB treatment, they're getting better, starting to look better. Now you put them on ARVs, and then 1 month or 6 weeks on treatment, they come in and now they're worse. The X-ray picture is worse, or the gland they've got is getting bigger, or their pleural effusion keeps on filling up, or they were AFP negative and now suddenly they're AFP positive at 2 months. So the clinical picture looks like it's getting worse. And the first thing we all go is, oh my God, he's got MDR TB. Or he's not taking his treatment. And some of them have what we call paradoxical iris. So what that means is the illness is not progressing at all. TB is actually getting better. But this patient was a lot sicker than we thought. And now the immune system is coming into the fray and is overreacting. Why does it do this? So this is just the general rules. It can occur early, sort of within the first 3 months. Can recur a little bit later. We know it's linked with a lower CD4 count, but we also seem to sometimes see with patients whose CD4 counts are not that low, but who had very high viral loads. And we think it's got something to do with a lot of antigen being around. So if you've got a big viral load, you put people on ARVs, you're not killing virus everywhere. Okay? So you've got all these dead virus. And there's something about this, all this antigen that's around, and at the same time, all this new CD4 counts, all these CD4 cells that's being made, that creates this massive over-inflammation. And it can be the classic ones we see as TB, but you can see the Streptococcus is another classic one that loves to iris. CMV, herpes can iris, shingles can iris. You get a variety of skin rashes that can iris. And the general rule is if you put somebody on ARVs, and within the first 3 months they get sicker, it's not the ARVs. We used to have in the old days, you would blame the D4 T or you would blame the TBI or whatever, some horrible side effect from the medication. Our ARVs has got relatively few side effects and very rare complications. So if somebody's getting sicker on ARVs, the first thing you worry about is iris. And you've got to figure out which one it is and treat it and help the patient to get through that infection. This is one of the slides that tries to show a little bit what they describe when they see it. And what we see is that all CD4 cells are not the same. Some CD4 cells promote different parts of the immune system. And for some reason, the ones that promote all the inflammatory markers, so particularly specific interleukins and specific interferons, gamma interferons 1, I don't know if it's on there. There we go, there's the beta. But they promote these different messengers, and the pro-inflammatory messengers, for some reason, those CD4 counts, the new ones, all seem to be those types. So that's one theory. But we don't really understand why iris happens, because quite often the iris is more dangerous than the actual illness that the patient has. This is just to show our increased levels of CD4 cells and interferon and the interleukins that gets made. Questions about iris? Iris will come up when we do TB again, and will come up when we do Cryptococcus. Okay. So we can't talk about virology and immunology and not say a few words about vaccine development. And it's quite current, because vaccine trials at some stage, we pretty much always, just give up. We're never going to get there with a vaccine. I've already mentioned some of the reasons why the vaccine is so difficult to develop. It's largely got to do with the fact that HIV has got a lot of variety. It's very small and changes all the time. And it gets very difficult to figure out a vaccine. You know, with our flu vaccine, our flu virus changes once a year. We have to have a new vaccine every year. Well, the HIV virus changes billions of times all the time. So we had to look at different ways of thinking about vaccine development. And so the trial you probably need to know about is called the HVTN 702 trial. It's on the radio station. Remember it for your exam. And it builds on a previous trial that was promising. There was a vaccine trial that took place in 2009. Oh, that might not be in your notes because this is brand new off the shelf. So there was a trial in 2009 which showed that 31%, I think they did it on soldiers, in Thailand or somewhere, and 60% of them in the first year, there was a 60% reduction of protection against HIV in the first year, and then the protection sort of waned. At the end of 3.5, 5 years, about 30% reduction in HIV infection. So there was 30% less HIV infection in people who had the vaccine. So they looked at that and they decided to improve the vaccine, obviously. It also includes booster shots. They've added various things to it, which makes it now very specific for HIV subtype C. And it consists of 5 injections basically over a year. It's a randomized controlled study. I think they're wanting to recruit about 5,200 people across South Africa. I think the main site's in Cape Town. I'm sure. And those people will be followed up over 3 years. So I don't know if you know how vaccine trials or any prevention trial works. Half the people will get the vaccine, half the people won't get the vaccine. They will all get the same advice about using condoms and being sensible and all of that. And then at the end of 3 years, they will look at the HIV rate in both groups and they will compare the 2 groups. And so it's probably going to be another 5 years or so before we will know whether this is something that is potentially useful or not. There's a little thing that just shows how the different trials have developed. Maybe I should WhatsApp that to me. And it just gives a summary of the development. It's different trials that's been building onto each other. Oh, look, it's 5,400 people that they're busy recruiting at the moment. And then do you all know about our one cure of HIV? So there was one patient in the world that's been cured of HIV. There's a photo of him. In the beginning, he was just known as the Berlin patient, but he's now been willing to say who he is. So now that we've done virology, we can understand how they managed to cure him. He is a homosexual man who got HIV in the early 2000s, and then he developed leukemia, CCL. And the physician who got to the point where he needed a bone marrow transplant, and the physician who looked after him decided to not only to look for the bone marrow donor to not have that CCR5 co-receptor. Remember we talked about that co-receptor that's necessary, and at about 1 to 5% of people don't have that receptor at all. So he went and he found somebody. I think they had to go through like 22,000 people to find that one person that they could get bone marrow from that did not have this, but they found that person. And then they did a bone marrow transplant. And so he's the only person in the world of science, several apparently everywhere else, that was HIV positive and is now HIV negative. And he has stayed HIV negative. The mortality rate for a bone marrow transplant is about 50%. So that's why it's not something we're going to be doing on the general population. But there was another patient in the last couple of years who also had leukemia with HIV, and they did the same thing, and it was not successful. So he did end up getting, the HIV did come back again afterwards. So it also doesn't look, not 2 cases, but a 50% success rate. But it's taught us a little bit, it's taught us a lot about HIV. What we do have more of is what we call functional cures, and people are getting quite interested in that. And that means that you take somebody and you put them on ARVs in primary infection and high dose ARVs. So you throw the book at them when they first, and you have to do within that first 2-3 weeks of getting HIV. Tricky to find those. And then what they do is they put them on treatment for 2, 3, 4, 5 years. There's different trials now looking at how long they would do that for. And then you would stop and you would see how long it takes for the virus to rebound. And there's 14 people they are following up in France. And there are some people where you then take they're still HIV positive if you do the HIV test, but their viral load in their blood is LDL. And so there's a lot of what we call a functional cure. can we find ways of, even if we can't take the HIV away, can we cripple it enough in your body that it doesn't actually re-emerge? So there was also a story of something called the Mississippi baby. It was a baby in Mississippi in America where they put this baby, they diagnosed HIV at birth, and they put the baby on a whole cocktail of ARVs, and the baby was on it for about 8 or 10 months, and then the baby vanished off the radar. And so when the baby came back, and just before she was 2 years old, when they did the blood test, they found that the viral was LDL. Everybody got very excited. And then I think it lasted for about a year or so, and then her viral load has gone back up. So we're still in the process of trying to find answers.